So colleagues, we are at the top of the hour. Welcome to our LabCoP Extended ECHO session for today. My name is Francis Ochen from the African Society for Laboratory Medicine, and I am your moderator today. Today we have two moderators, and I'll be introducing my co-moderator very shortly. This session will run for 1 hour, and we'll take 3 presentations. It's quite loaded before we get to the questions and answers. Kindly join the discussions through the chat. That is your one option, and generally the only option that is available for you to join the discussion. We have language interpretation services, so please keep to either English, French, or the Portuguese channels. Our session slides will be shared with you through our available social media channels that most of us are quite aware about. Our session today really focuses on surveillance of histidine-rich protein 2 and 3, looking at some of the guidances that are there, the tools that are available, and the results from 2 surveys that are done in Uganda and Ethiopia. I will leave the details of the introductions to my co-moderator, but let me just at this point introduce my co-moderator and hand it over to him. And so our co-moderator today is Dr. Evans Mathebula, and Evans is a Medical and Scientific Affairs Manager for Africa with Abbott. And so let me take this opportunity to hand it over to Evans to steer us through this session. I'll then join at the end. Thank you.
Thank you very much, Francis. Good afternoon, everyone. I would like to extend my warm welcome to all participants in this webinar that is going to be themed Navigating Malaria Testing in the Era of Gene Deletion. I would like to extend my sincerest thanks to the entire ASLM team, as well as to all of you who have graciously taken the time to attend this meeting. As I've introduced, I am Dr. Evans Mathebula. I am the Scientific Affairs Manager for Africa at Abbott and a leading provider of medical diagnostics and innovation solutions. Malaria continues to be one of the world's leading health threats, resulting in an over 600,000 global deaths each year. The burden of malaria remains disproportionately high in sub-Saharan Africa, accounting for about 90% of malaria cases and global deaths. Numerous research publications have demonstrated the growing prevalence of the HRP2 deletion and its threat to undo the progress that we've made towards eliminating malaria by 2030. This is due to the fact that the HRP deletion negatively impacts the performance of diagnostic tools and thus jeopardize the malaria control efforts by countries. It is through technological innovation and collaborations that we will really make an impact in reversing the effects of gene deletion. It thus will be essential to conduct regular and systematic monitoring to evaluate the incidence and prevalence of these deletions. Additionally, the World Health Organization has published a response plan in support of these national malaria control programs and its implementing partners in countries where the frequency of HRP2 and 3 deletions are high. So this webinar is shaped in a way to attract your interest and be insightful. It is my hope, and also the hope of Abbott and the entire ASLM, that we will leave this webinar with more knowledge and perspective than when we joined the webinar. I look forward to the discussions, and I thank you very much for joining. We have lined up 3, as Francis has already indicated, we've lined up 3 speakers that will be taking us through the webinar. Let me just quickly share the profiles of 3 speakers. Dr. Xavier is our global clinical strategy manager at Abbott Rapid Diagnostics, and will be going first to present a WHO response plan. This will be followed by Mr. B. Gidi, who is the team leader in the malaria and NTD's research team in Ethiopia Public Health Institute. And lastly, but not least, Dr. Agaba Bosco, who is a postdoc scientist at LSHTM and a senior research fellow at MUST. Is a coordinator at Malaria Genomic Surveillance and Emerging Pathogens in the malaria program in Uganda. Colleagues, thank you very much. I think in this interest of time, the presentation will follow seamlessly, starting from Xavier up to Dr. Bosco. This will then be followed by a Q&A. And thank you very much once again for joining the meeting. Over to you, to our first speaker, Xavier.
Thank you very much, Evans. Do you see the slides on my end?
Yes, we can. Thank you.
All right. Okay. And I'm not quite sure if my camera is working, but I tried to put it on. Hopefully you can hear me well and see the slides.
We can.
Yeah. Thank you. Okay. All right. Good. Yeah. It's really my great pleasure to kick off the presentation at this webinar, at this seminar. I think it's we're trying to tackle a very important topic in the space of malaria today, this HRP2 gene deletion and what it means. And I'm very much looking forward to the speaker's presentation that we're gonna have following up that will show real data from countries, from surveys as to what is the reality of this deletion issue. And I'm just gonna be taking 10 minutes of the time here to present some background on it and also highlight the WHO protocol that is recommended for surveys of deletion. So in terms of background, the first report of this HRP2 gene deletion issue is actually already quite old. It was back in January 2010. By Dionisia Gamboa, Xin Cheng, and colleagues who published a paper in PLOS ONE, reporting actually the quite high prevalence of this deletion occurrence in Peru, in the Amazon region, right? And if you look back at that paper from 2010, actually there is already a lot of consideration about the issue that are spelled out in the conclusion of this paper. Obviously, they say, well, that study was conducted in Peru, but obviously, the whole Amazon basin is endemic for malaria. So it was unlikely that the issue would be restricted to Peru. And they clearly say, well, malaria transmission knows no border. Unlikely that the parasite lacking HRP2 would be confined to Peru. So they go ahead and highlight the need for understanding the magnitude of the issue and saying that, well, understanding where the presence of this parasite lacking HRP2 and 3 would be before, and 2010 was actually the time where RDTs were being implemented. So before RDTs would be implemented at a large scale, it would be wise to actually understand if similar issue would occur elsewhere, calling out for investigation that should be done to monitor the presence and spread of those parasites. But I think it's fair to say that this issue has been considered very much a peculiarity of Peru, of the Amazon region for a very long time. And so to be sort of restricted there and was sort of largely ignored until we realized back in 2018 that it was actually spreading and it was present elsewhere, and especially in Eritrea, where a very high rate of false negative RDT led to investigation and the identification of a similar issue occurring in Eastern Africa. And that led WHO to issue a comprehensive response plan back in 2019, covering recommendation not only about what RDT to use in such area, but also importantly how to do surveillance and defining recommended protocol, which we'll talk about, and also when and how to switch RDTs if you're facing such an issue. And I'm putting the links to these different WHO resources. I also wanted to highlight the resources that MESA, the Malaria Eradication Scientific Alliance, is putting together. They have, you see the link on that slide, they have not only a community of practice around HRP2 deletion, but they also have a website that sort of lists all of the tools and that exist to address this issue. And I think this is a very good resource that people interested in that space should look at. So if we move to this WHO surveillance template protocol, it has been designed to basically guide surveillance for HRP2/3 gene deletion in malaria endemic country. And obviously, it's nice to have such a protocol because it's going to help, you know, work according to best practices. I think it's also very nice because it enables data to be generated in a similar manner and to be much more comparable, which is something that is a bit challenging when people go about looking for HRP2 deletion, but everyone doing it slightly differently, using different protocol, and that makes data comparison challenging. So very briefly, if we go through the key aspects of this protocol, it calls for, you know, looking at febrile cases, so symptomatic malaria in a cross-sectional manner at multi-sites, and it's basically look at what is the prevalence of this HRP2 deletion. The sample size recommended is 600 PF cases for a domain. So if you want to assess a given district or a given region, well, these are 600 cases you should be testing in that space. And they recommend to go to 10 health facility with 60 cases per facility, ideally. So relatively big effort, big sample size and big effort. And the way it goes, it's recommended that basically you would test everyone with a WHO recommended HRP2 based test, and in parallel with a non-HRP2 method, be it an LDH, RDT, or microscopy. And those samples that are negative by HRP2 based RDT but positive by microscopy or LDH test, then you would go on and assess those for deletion by doing molecular analysis and or serological analysis. And there are recommended protocol to go about assessing deletion. I won't go into details there because of time, but those exist and are recommended protocol. Now, you have basically three outcomes that can come from such a survey. Essentially, either you have a low, you have no deletion or a very low proportion of deletion. You are below this 5% threshold, and you're highly confident that you're below it because your upper limit of the confidence interval would be below it. This is outcome one. Or you are above that threshold with high confidence. So your estimate is above this 5%, and you lower limit of the confidence interval would also be above this 5%. So you're pretty sure you have a serious HRP2 deletion problem in the domain that was tested. Or you're unsure, you cannot conclude because this 5% threshold is contained within your confidence interval. So out of the outcome one, basically, you don't have an issue currently, and the recommendation is to repeat a similar survey within 2 years or in the next 2 years. Outcome two, well, it looks like you have a high prevalence of deletion, so the recommendation is to switch to an RDT that doesn't rely exclusively on HRP2. And again, there are some projects recommended by WHO for this. It's important to say that this threshold of 5%, and it's also, well, two things. It's important to make the distinction between deletion and false negative. So it's 5% false negative by RDT that is the threshold. And you can have deletion, but sometimes you can have samples still detected because you have multiplicity of infection. You can be infected by both deleted and undeleted. So it's important to understand it's 5% of false negative. And if you have that, it's, well, the second point is that 5% threshold was selected because it is somehow when you're going to start to miss 5% of cases with your HRP2 based RDT, that it can be offset by non-HRP2 based RDT that are less sensitive today. So in other words, what you're going to lose by switching to an LDH based RDT that is going to be slightly less sensitive than HRP2 based RDT is offset by the fact that a lot of your infections are anyway HRP2 negative, and you would miss them in any cases. And then outcome three, when you're inconclusive, well, the recommendation is to repeat within 1 to 2 years, or to actually keep testing to increase the sample size, basically reduce the confidence interval, and possibly get confidence that you are either below or above this 5% threshold. WHO hosts these so-called threat maps, where they report data about different issues for malaria. One of them is this HRP2/3 gene deletion, and they have a panel about the surveys. So you can look at what surveys are being planned, ongoing, or completed, and we can see that there are quite a number of ongoing surveys or survey plans in Africa at the moment. And they also have a similar map about data on HRP2 deletion, and you see surveys or data reporting occurrence of deletion are those red dots on this map. And it's quite clear that while this issue is not widespread everywhere, it has been detected pretty much everywhere at a low intensity. So out of the 47 countries surveyed, deletion were identified in 40 of those. And in the last 5 years, not only Eritrea, but also Djibouti and Ethiopia had to switch to alternative RDT because of this issue. So I'll stop here, but in conclusion, so since it was identified in 2010, this HRP2/3 deletion has been found to occur in actually the majority of malaria endemic countries or PF endemic countries. It's sort of a pernicious issue because it can, if you don't look for it, it can go on and spread in an undetected manner relatively easily until it actually severely impacts the effectiveness of HRP2-based RDT and ultimately your ability to adequately diagnose and treat patients. So it can be pretty severe. And so that's why those well-planned surveys are actually essential to monitor the situation, understand what's going on and how it evolves. And that's why those WHO developed protocols are so useful. But as we've seen, it's large sample size, it's relatively intense effort. As I said, this 5% threshold is really based on the fact that historically LDH-based RDT are less sensitive than HRP2-based RDT. So if you don't have deletion, you shouldn't switch in such a case. But we can also imagine that if RDT manufacturers would be able to close that gap in sensitivity between HRP2 and LDH-based RDT, then the switch could happen at a lower deletion prevalence or even preemptively. And that would render this need for, ongoing surveys less acute in that regard. So yeah, thank you very much. I'll stop here and we can move on to the next presentation. I'll stop sharing my screen so that the next presenter can take the lead. Thank you.
Thank you very much, Xavier. Mr. Gede, please share your slide. So Mr. Gede will be sharing the emergence of PFF, HRP2 and 3 gene deletion for the escape of Plasmodium falciparum detection in Ethiopia. So this would be a country-specific data. We can see your slide. Please go ahead, sir. Thank you.
Thank you very much. This is Bokrotion from Ethiopia and working for the Ethiopian Public Health Institute. I'm going to present the Ethiopian emerging PF-HRP2 gene deletion for the escape of Plasmodium falciparum detection. Okay, the overview of malaria, and we have conducted 2 surveys, phase 1 and phase 2. I will be present this 2 surveys result. In Ethiopia, falciparum and vivax are the most common malaria in the commonly known ratio of 60 to falciparum and 40% of the vivax. And Ethiopia is the second populous country in Africa, and about 75% of the population is at risk to getting malaria. So Ethiopia have been launching elimination program since 2017, a stepwise malaria elimination to align with the vision of malaria-free Ethiopia by 2013. Currently, there is a surging of malaria, especially from starting from the pandemic COVID-19. So in the last year, in 2022, more than 5 million episodes have been reporting. And also we have get some challenges on the diagnostic, especially on the drug resistance and the resistance to the HRP2 targeting gene RDTs. So the rapid diagnostic test is offers for community-based diagnosis and allows in the treat and test and treat strategy in the country. And as of 2020, more than 7% of malaria being detecting using the RDTs in the community level. And the common challenge was the manufacturing, like the lot and product quality have been checked in, and storage and transportation and the operator error was the most common, but the gene deletion is the new coming, which is the targeting to the detection using the RDT. So as you know, the reliable antigens which are known by the current RDTs to detect malaria are the HRP2, PLDH, and aldolase. But the HRP2 antigen is the most preferred because of the high abundance in the bloodstream, repetitive binding epitopes to increase the sensitivity. And it is specific only to PF. And so most countries, including Ethiopia, uses this highly sensitive PF HRP2 targeting, detecting RDTs. In Ethiopia, in many countries in Africa and Asia, as previously presentation have been reporting PF-HRP2 gene deletion, where the first was from Peru. But in 2016, a high prevalence of HRP2 gene deletion reported in Eritrea. And the Ethiopian Public Health Institute with consulting partners and the ministry, especially with the WHO, the problem conceived and proposed to study this whether the emerging HRP2 gene deletion is found in Ethiopia. By 1718, we conducted a study in about 108 health facilities in 11 districts from Tigray, Amara, and Gambella, in bordering to Sudan, Eritrea, and so our target population was malaria self-presenting patients screened using two kits or RDT kits, the CareStart PF HRP2, PV, PLDH, since Ethiopia has abundantly with both species. And the another one was the SD bioline, PF HRP2, PLDH, targeting antigens to detect the malaria. So we consider that in the PF HRP2 and in the CareStart and PF HRP2 in the bioline, if negative, we consider, and also in the PLDH positive, we consider this as discordant and suspected for HRP2, and all discordants and 20% of the concordance of PF samples were selected for further analysis, and we assessed using the PCR assay and Luminex-based serologic assays. Whole genome sequencing and molecular inversion probe deep sequencing have been analyzed using with the different partners. So this is the regions in Ethiopia, and the right side is the red colors, which areas that have been conducted this study in bordering Eritrea, some part of Sudan, and South Sudan from Gambella. And having this point, 824 samples were selected from Amhara, Tigray, and Gambella. The samples were sent to University of North Carolina for molecular analysis to confirm the species and PF-HRP2/3 qPCR assay. And out of this, about 613 samples were confirmed for the falciparum infection and were eligible for the PCR and qPCR HRP2/3 assays. And in the results, it's been about 22% were double deleted, which is the PF-HRP2 and 3, and 32% were only for HRP3, and the 4.6 were PF-HRP2 only deleted. Among the discordant profiles were about 64% were double deleted, and 8.5 were only for HRP2. and about 16% were the PF-HRP3 only deleted. What we have here, another issue, is just a high proportion of samples with HRP2 positive and detected by RDT. By RDT were negative for PF-HRP3 by the PCR, while we're detecting it in around 42%. This is the RDT profiles, what we are choosing in the right side, the red color is. So again, the population level estimation in the total PF case was about 9.7 cases were deleted, even though it is highly heterogeneous in the regions. And the Tigray was bordering the Eritrea and some Sudan were 15%, and the Amhara were 11%, in Gambia 1.5%. So having this result, we large surveyed districts bordering with Eritrea, Sudan, and South Sudan confirmed the presence of HRP2 deleted parasites, which is indication for the false negative results from the RDT. And we recommend the Ministry of Health to have a consideration for policy change. And this study was published in Nature Microbiology. And the ministry have decided and reviewed the result, and they consider that this is inconclusive since it is not nationally representing the sites where, as you see, in neighboring to the border sites. Therefore, the decision was made to conduct a nationwide PF-HRP2 gene deletion survey in the country. So by 2021, a nationwide PF-HRP2, HRP3 gene deletion survey being conducting as a second phase. This study was to determine the national level prevalence of the Plasmodium HRP2 gene deletion in the country, and additional 114 sites were added to the first phase samples, and this is, as you see in the map, the red colors are the health centers, which covers all the regions in the country. But in the second survey, we changed one method, especially in the rapid test. The care start was as it is, but due to some specificity and sensitivity issues, we changed the byline by microscope. We considered the discordance PF-HRP2 negative in the RDT, and microscope was Plasmodium falciparum positive. So again, in the discordant results, we have got a similar result with the previous study with 68.7 both deleted and 3.5 only PF-HRP2, and 40.5 were only for PF-HRP3. And we get about 13% were non-deleted from the discordant results, and we got about 3% from the concordant results, the delays. In the next surveys, the population level prevalence of the gene deletion was 7.5, still, which is above the WHO threshold. So by these two studies, we recommend to the ministry policy changes, recommend to the Ministry of Health. So by 2022, a policy brief was prepared and the guideline was revised. PF-HRP2 RDTs changed to an alternative non-PF-HRP2 RDTs, and currently the ministry is in process to procure and distribute of the PLDH, the based antigen for detection of malaria, and PV-PLDH is. So this is the recommendation letter signed by the State Minister of the Health Minister. And also additional, we get another malaria artemisinin molecular markers associated with the diagnostic in the diagnostic resistance. So this is 6-2I is high prevalence in the northern part of the country. Again, we are going to confirm whether it is highly related with the clinical patients, since the marker is related with partial resistance, but still the drug is working in Ethiopia, especially the artemisinin part is working, but still we are ongoing to confirm whether the prevalence of 6-I is related with the clinical. Currently, we are using the multiplex PCR assay is established in the Ethiopian Public Health Institute, and some monitoring and follow-up for the next follow-up of the HRP2 gene deletion is conducted in some selected surveillance, and evaluation of new non-HRP2 kits is in progress. So Ethiopian Public Health also always acknowledge toward this to the WHO, UNC at Chapel Hill, Brown University and CDC, global funds through the Ministry of Health. And finally, the study participants and my colleagues are acknowledged. Thank you very much.
Thank you very much, Mr. Kiri, for sharing the Ethiopia experience. Dr. Gaspo or Bosco, can you share your slide, please?
Gide, can you put down your slide?
So Dr. Bosco will be presenting on the threats of the PF-HRP2 deletion in Uganda.
Yeah, thank you very much, Francis. I want to confirm that I'm audible and you can hear me that side.
Perfect.
Yes, Bosco, we can hear you.
Very good. Francis and team have already done a good job to introduce me and my other speakers, so I will not waste time on this slide. So today I'm very, very happy for an opportunity to speak at this very important forum on a very important topic. I'm going to follow this presentation outline just for the case of understanding the terms that I'm going to use as we present along. HRP2 is Plasmodium falciparum histidine-rich protein 2, which is a gene that is located on chromosome 8 of the parasite genome. And HRP3 is Plasmodium falciparum histidine-rich protein 3, a gene that is located on chromosome 13. So these two genes have similarity in amino acid sequences, and their protein actually cross-react. So as Xavier said, this problem started in the Amazon, and the deletion actually happens within the subthermic region, and it is due to the breakage around that area of the genome. This problem has now spread to Africa, and many countries have now reported the presence of gene deletions. So what I show here is a map of Uganda showing the malaria burden and the transmission levels, intensities in all regions of Uganda. So we know that malaria is still a big problem in Uganda, not only in Uganda, but in sub-Saharan Africa. And one of the key interventions for malaria control is diagnosis. And we know that the WHO now recommends that every case must be diagnosed and confirmed in the lab before treatment is administered. And we know that RDTs are now the main diagnostic tools for malaria diagnosis in sub-Saharan Africa. Actually, in Uganda, about 80% of total malaria testing is done by RDTs. But we know that these RDTs are now threatened by HRP2 gene deletions, and we know that alternative RDTs exist. However, these are often slightly expensive, but also less sensitive, but also the thermostability in the field is compromised. WHO recommends that surveillance systems be established to continuously monitor and track these gene deletions. However, we know that most countries have not established routine surveillance systems to be able to detect deletions. What's the problem? The problem we are trying to deal with is that the emergence of HRP gene deletions threatens the utility of HRP2 RDTs, which are the main diagnostic tools that is used for malaria testing in sub-Saharan Africa. And yet, HRP2 RDTs are the predominant malaria tests. Of course, more than 80% of testing is done with these tests. Now, parasites with deletions do not express the HRP2 target protein, which these RDTs target. And in the absence of this protein, we are going to miss parasites. And so patients are going to go back untreated. Misdiagnosis may lead to increased malaria transmission, morbidity, but also these cases may progress to severe malaria and death. As I mentioned before, alternative RDTs exist, but they are often expensive, less sensitive, and they have poor stability in the field. So Xavier already presented this data. The WHO continuously publishes these maps that shows where surveys have been done and where we still need to do the surveys. And this is very important for tracking surveillance for these deletions. In Uganda, we have done 2 surveys so far. Survey 1 was done in 48 districts of the country, and the map I show on top right shows the regions and the sites, the distribution of sites where we collected these samples. There are thousands and thousands of samples that were collected from symptomatic children aged 2 to 10 years of age. And we used HRP2 RDTs and blood smear microscopy to screen these samples. The map I show on right bottom shows the discordant samples, discordant between RDTs and microscopy. And in areas where these gene deletions are developing, you are going to see most of those cases. You have patients who are HRP2 RDT negative, but they are positive on blood smear microscopy. So in survey 1, we used, in terms of laboratory assays, we used a conventional PCR where we include these known laboratory strains. We have a strain that is that has both genes intact, HRP2 and HRP3, and then we have a strain 3BD5 that misses, that has deleted both genes. So these controls must pass on electrophoresis. As you can see, 3BD5 has no bands here, but also here. And 3D7 has bands here and here. So these controls must pass to prove that your assays work very well. So what I show here is a summary of the conventional PCR, right from extraction, PCR setup to DNA amplification, up to gel electrophoresis. So as a summary of our results from survey 1, I'm mainly interested in here where we had 10 isolates that had double deletion of HRP2 and HRP3, and you can see that all the 10 isolates were RDT negative, but blood smear and PCR positive. So we mapped out using geographic information system where these deletions were detected in terms of regions, and we can see that most of the HRP2 deletions were detected around the eastern region, but also in western region. We did the second survey in 2023, and we had 3 objectives: to estimate the prevalence of suspected false negative RDTs, but also determine the prevalence of HRP2 deletions among those false negative RDTs. But we also looked at NPF species. So what I show here on the map on the extreme left is the sites that where we collected these isolates, thousands and thousands of them in the 4 regions of Karamoja, Sinai, Lango, and Acholi. And these are the number of samples we collected from those regions. So what I show here are the discordant results, discordant between non-HRP2 RDT and HRP2 RDT. So in the second survey, we did not use blood smear microscopy, but we used 2 RDTs, a non-HRP2 RDT and an HRP2 RDT. So the summary of our results from survey 2 where the lab methods that we used in our survey too, we amplified the fragment of each HRP2, HRP3, RDTs, and the human tuburin. And this was a real-time quantitative PCR that amplifies these four fragments simultaneously. And in terms of results, we see that we saw only one isolate that had HRP2 deletions. Actually, it was double deleted. And in order to confirm that this isolate is actually HRP2 deleted, you have got to prove and show that this isolate does not actually express HRP2 protein, and you do this with ELISA, it's a Luminex ELISA. So this isolate must also be able to amplify MSP1 and MSP2, which are single copy genes, just like HRP2. And also this proves the quality of DNA to show that the non-amplification of the gene was not due to poor quality DNA. But also all these controls must pass, which are the laboratory strains with known HRP2 status. We have published our work in several journals and it can be accessed for reference. So I wanted to share this sequence of steps that we followed in implementing our HRP2 surveys, and this is important for those countries that are planning to conduct surveys. It is important to engage stakeholders, especially at national level, so that all of you get the same level of understanding. Important to identify survey areas and coverage the areas that are going to be covered by these surveys. And mostly these are areas where field concerns of false negative RDTs are coming from. So you have to prioritize these and position sites there. You need to quantify the need in terms of resources and supplies, but also do resource mobilization. These days, Global Fund and major donors can allow inclusion of surveys in the grants. You have to do protocol and ensure that the NMCD personnel, malaria program personnel are included on those protocols for acceptability, but also utilization of findings. You have to constitute competent teams who are going to collect these samples, but also preparedness in terms of lab capacity to test these, especially the genomic assays. And if there's no lab capacity, then you have got to have the material transfer agreements to ship to alternative labs. So these are important considerations while running those field surveys. And this is important for those planning to run the surveys. It is important to position sites, especially where you have concerns of false negative RDTs, but these sites must also be representative depending on your malaria situation and transmission intensity in your country. These are the standard WHO record forms where you record results of HRP2 RDTs and the non-HRP2, but there is a tendency of interchange of results. And then number three, you have to make sure that there is good correction of DPS, which can be a mess if not done very well. In terms of microscopy, if you are using HRP2 RDTs and blood smear, you've got to make sure that you have competent slide readers who are going to do quality work. So it is important, number five, to work within the existing structures so that you don't have to constitute your project teams parallel to the existing structures, but also supervision was important to make sure the work is done very well. There are potential bottlenecks while you implement. There's going to be need to build capacity to run these surveys, especially the molecular testing. Most of the surveys have been done in a project mode, and these normally collapse, the efforts normally collapse once the project is done. The routine surveillance system is not very well strengthened during implementation to take on periodic surveillance. But also in terms of communicating HRP2 deletion results, it's very challenging, especially in cases where you find you have deletions, but they are below 5% cutoff. How do you communicate to clinicians that no, you are going to be missing parasites, but these are still below 5%? So this has a potential to revert to clinical diagnosis. So in some cases, you may consider introduction of alternative RDTs alongside the HRP2 RDTs. So you have got two distribution systems and the alternative HRP2s are going to regions that where deletions have been detected. So you have got to have an efficient supply chain system. So potential issues for consideration for future surveys. We've got to start thinking about alternative RDTs that target different antigens other than HRP2, but we also know that there is a limited number of approved non-HRP2 RDTs by the WHO. We've got harmonized detection methods, as Xavier indicated. We did a systematic review here, and we saw that 100% of the surveys actually followed the cross-section design as recommended by the WHO, but only 35% of these surveys enrolled symptomatic individuals. So the rest of the surveys were enrolling asymptomatic individuals, which is not recommended by the WHO. But also in terms of spread and distribution of sites, you had what Xavier said, the sampling framework, 10 sites per domain, per region, 60 patients per site. These are 600 patients per region. But only 42% of the surveys complied with that requirement. But also in terms of reporting, other surveys report HRP2 and HRP3 deletions, while other surveys report only HRP2. So there is variation in reporting, which makes standardization and comparability of data very difficult. So the WHO has got a network of specialized laboratories that are accredited to run these surveys. And for us in Uganda, we've been collaborating with Dr. Karid of the London School of Hygiene, where I'm also an investigator, but also in Australia with Dr. King. But the question is, the WHO needs to expand this laboratory network to accredit some more laboratories in Africa to be able to run quality molecular assays for detection of gene deletions. This is the facility in Australia where I ran the surveys, both surveys from Uganda, samples from Uganda. And I acknowledge everybody, including co-investigators, the WHO collaborating centers, and the funders. Thank you very much. Back to you, Chair.
Thank you very much, Dr. Bosco. That was a whole lot of work, and thank you for sharing. I think we will now move seamlessly to the Q&A. We have a set of questions that we have been asked by the colleagues online, and I will maybe kick off Xavier with one very important question that they've asked here. So what are the drivers of these deletions, and are there any other stable biomarkers that can be used to step up the rapid diagnostic tools? And also, do we have any diagnostics in the pipeline?
Thanks, Evans. So yeah, I think the driver question is a very good one. I don't think it's very clear at all. What we know is, those parasites, they were found in Peru before RDT were used at large scale, right? So even though you can imagine that to use the widespread use of HRP2-based RDT could drive the spread of this deletion, because essentially as a parasite, if you are not detected by the RDT, then people are not treated, especially if you have a strong policy that recommends, treat only in the basis of a positive test. And so they would have an evolutionary advantage. But they were found so it's clear that, use of RDT could spread those deletions, but they also happen to occur and to be present without the use of RDT. So they don't seem to have a disadvantage per se, right? So they can, and I think it's quite clear, without knowing all of the details, I think it has been established that they did not, move from South America to Africa. They evolved independently. And that gene, as we know, that protein is expressed at very high levels. So you can imagine it takes a lot of energy for the parasite to produce that protein. And if it can't survive without it, potentially that means there is a lot of energy the parasite can dedicate to something else. So it's also important to understand that there are like LDH, right, lactate dehydrogenase, which is another biomarker used for RDT. This gene is essential. So you won't find it deleted. Parasite cannot live without that gene, without this biomarker. So it will be present. The only problem is that those products tend to be not as sensitive as HRP2 based RDT. Because the antibodies are less good, because the biomarker is less abundant than HRP2. And so there are a lot of efforts, including at Abbott, to develop new tests that have better LDH performance. And we are definitely working on this. And there are some products out there, and WHO has a list of products that are recommended for use in area of deletion that exist today. And yeah, I'll stop here. Thanks.
Thank you very much, Xavier. For you, Mr. Giri, so in case of the study that you've conducted with other colleagues, you conducted the study at the border area. Did the study consider the cross-border movements of the participants? And how would that have affected your outcome?
Yeah, there have been a cross-border, but even this gene deletion distributed to the another part of the country that we detected in the second phase of the study. So there is some cross-bordering issues. At that time, there was displaced people from Eritrea, and we detected this RDT both from the community and outside of these areas.
Thank you. Thank you very much. Dr. Bosco, please, to wrap out, you spoke a lot about the surveys and the sequence on the implementation, and also the potential issues to consider when you are implementing these surveys. In terms of the policy, what do you think recommending a blood smear microscopy to confirm all RDTs that are negative would be feasible? Do you think it's something that we should be leaning more towards, or should we try to innovate and get more non-HRP2 dependent RDTs?
Yeah, I think those are all available options that we can consider, especially for countries where the prevalence of HRP2 deletion has reached 5% and above. So both options you have mentioned are feasible options, but I do think a lot of effort should be put in research into identification of more feasible and potent target antigens that can now be able to introduce novel diagnostics. But for the moment, as we struggle and monitor the prevalence, I think countries that already have high levels of deletions may have to consider putting in place an algorithm for diagnosing and treating those suspicious patients who are likely to have HRP2 deleted isolates.
Okay, excellent. Thank you. Thank you very much. Colleagues, unfortunately, there is quite a few other questions that have been asked in the charts, but in the interest of time and respecting all the participants and also the speakers' time, we will stop at this point. And any other questions that you might have, please keep on sharing those questions. We will liaise with the ASLM to get those questions and probably feedback to you. So we really want to thank you for your time. We understand that everyone is quite busy, and we truly want to thank you for making this time to join us in this experience sharing, and also participating and contributing with all the questions that you've said. So in closing, we started off with Xavier, who presented on the guidance from the WHO in the conducting of surveys, and also the importance of conducting those surveys. also shared how the WHO is making sure that all those information is being tracked, the support and the guidance that is being provided. He also spoke about the threshold of 5%, which and then informs the next steps in the surveys, whether you continue with conducting the studies or you then implement the second phase of those surveys. And then he also mentioned that majority of those HRP2 deletions are actually observed in malaria endemic countries. So this is a very significant milestone, and we thank the WHO for providing that guidance. We then move to Mr. Gidi, who also indicated that he conducted 2 surveys in Ethiopia. The first survey was conducted in 108 districts, 11 districts and 108 facilities. And the second study was conducted in 11 facilities, and they saw up to 72.7 gene deletion by either double or a single mutation, which would be quite considerable looking at the effects that a gene deletion would have in a diagnostic or the malaria control effort. We then move to Dr. Bosco, who initially gave us a very nice molecular biology class and gave us the genetic location of the HRP deletion. Also, they also did a study in 48 districts, 2 surveys, and he also gave us a very nice sequence of implementation and also the pitfalls and all the potential issues that to consider when a country or MOH is undertaking these efforts to implement these HRP2 deletion protocols. So we really want to thank you for your efforts, and this has been very insightful, at least for me, as I indicated initially, that I hope that you will leave here with more insights than when you came in. I believe that we have managed to do that. So thank you very much once again for joining us, and over to you.
Evans, thank you. Thank you very much. What a fascinating session, colleagues. And I am not going to add or take away anything, but just as we do the final statements related to this session, let me ask Xavier, do we have anything in your kitchen that is cooking to support the development of RDTs that may not necessarily be based on histidine-rich protein 2 or 3? You can answer that question and also give the overall closing remarks from our presenter's side.
Yeah, thank you very much for this question. So the answer is yes, we do, and we have communicated publicly about that at the latest ASLM conference. So yes, we have a project that has been developed with the support of the Bill and Melinda Gates Foundation in close partnership with Fine and Path, that is trying to close that gap of sensitivity between HRP2 and LDH and provide a easy to use solution for these areas of high prevalence of deletion. So the answer is yes, and I think the closing remark, just to say again, thank you for the presenter. I think it was really insightful to get real life evidence from different countries, different regions about that issue, and it is something that has to be taken seriously, that can profoundly affect the performance of or our ability to correctly diagnose and treat malaria. And so it has to be definitely something that has to be kept in check. And it's good to see that there are not only protocols and tools to support surveys and understand the magnitude of the issue, but also tools coming up to address it when the issue manifests itself in countries. Thank you very much, and thank you.
Thank you very much, Xavier. Thank you, Bosco. Thank you, Gide, Evans, my co-moderator, and Cassandra, who is in the background, who supported really the preparation for this session. We are actually at the top of the hour, but colleagues, as we are now aware, the agents that we are actually running after are also getting creative and trying to evade us. And so we need to keep our eyes on the ball and make sure that we do not lose track in terms of providing diagnostic services. and this should actually be quality diagnostic services. So thank you again to the team and everyone who joined us today. And we will be making the next announcement for our upcoming sessions very shortly. And just keep on the lookout for those sessions that are going to be equally exciting, like the one we've had today. Thank you again, and do have a very good afternoon, morning, or evening, depending on where you're joining us from.